Good morning, ladies and gentlemen, dear colleagues. It's really an honor and privilege to be here in this beautiful city of Vilnius and to discuss with you the access, or better to say the barriers to access to key populations. So as you know, well, I'm going to mostly focus on HIV infection because this is actually the only infection among the three of them discussed today that is curable and really has a potential towards elimination as a public health threat. And besides, I'm a clinician dealing with many HIV positive patients, so I can really speak of my personal experience. So as we've heard today, among 14 million of HIV infecting throughout Europe, the driving force of HIV epidemic in Europe are people who inject drugs. And we've also heard that men who have sex with men, particularly those who are HIV infected, are definitely, particularly in the last years, at the increased risk of contracting HIV infection. The risk of transmission, of course, is disproportionately affects prisoners due to known reasons. And in Europe, we should not forget and neglect the migrants where the infection is higher compared to general population. Moreover, studies have shown that globally more than 80% more than 80% of newly infections in Europe and 60% of already existing infections belong to people who inject drugs in Europe. So as you see in Eastern Europe, nearly 2 million of people who inject drugs are chronically infected with HIV infection. And moreover, studies have shown that more than 80% of HIV positive people who inject drugs are HCV co-infected. As already said, particularly over the past years, the incidence of HCV infection has been very quickly increasing in HIV positive men who have sex with men, but trends differ among European countries. We'll hear the talk of Jürgen Rockström tomorrow. However, studies have shown that more and more MSM with HIV negative status are also increasingly HCV positive, as we've already heard the talk of Miloš Percivski today. Besides, there is, among the studies from prisons, which are not many, we can see that the prevalence of HIV infection among incarcerated people is mostly between 5 to 20%. However, in some countries it goes even up to 60 or even 80%. And please don't forget the migrants, because according to the latest ECDC report, within the total number of HIV cases per country, quite a huge burden represent migrants, particularly in some countries, and as you can see also in the Central and Eastern European region. Luckily enough, with the advent of direct-acting antivirals, as you know, they work also in key populations. These are the studies from the very beginning of the DAA era. They work in people who inject drugs. However, this is the latest study showing that that efficacy of DDAs in ongoing drug users is quite comparable to non-injecting population. And moreover, these drugs do not work only on the individual, but also on the epidemiological level, meaning treatment as prevention. And this is an excellent study recently published from Australia showing that introducing regular screening and immediate introduction of DAAs in needle and syringe programs, as you can see, in merely 2 years of implementing this program, there was a dramatic decrease in the prevalence of HCV RNA positives. And also, these are the data from the Netherlands. Only 1 year after unrestricted DAA availability in the Netherlands, the incidence of acute HCV in HIV positive MSM decreased by 52%. And this is also the latest report from Iceland when they introduced TRAP Hep C program, which offered all inmates in prisons screening, diagnosis, and treatment with DAAs. As you see, in merely 2 years, the prevalence of DAA of HCV RNA dropped by 76%. So it's clear that the treatment works in hepatitis C. So all the distinguished international institutions call for earliest or immediate treatment, especially in key populations. But But as you know, this is the reality. The proportion of those who got treatment or who were cured, particularly this is the status for people who inject drugs, is really shown to be very low. Why? Because this is the latest European Liver Patient Association study from 25 European countries, showing that in many, many countries, key populations are not the most commonly targeted with HCV ongoing activities towards HCV eliminations. We know from the interferon era, it has been study proved that there are several barriers to access to HCV care from the side of the patient, practitioner, the system, as well as the policy. However, the burden was quite different in interferon era. Now we live in an interferon-free era, so many of these barriers can be actually omitted, and we definitely must focus on the system and policy barriers. This is the slide from 2016. This was the year of introducing WHO strategy towards viral hepatitis elimination, and as you see, many countries, particularly in Central and Eastern Europe, did not report on having national strategies or action plans for the management of hepatitis C, and even if they reported on having this policy for the management of hep C, they did not necessarily include people who inject drugs. Well, over the past 2 years, the situation has improved, and this is the latest report from WHO showing that many countries, many countries already have these elimination goals that are achievable, and many of them are developing the action plans. But as you see, the policy is not enough. Setting the policy is not enough. We need to adopt this policy into the real-life situation, into the real-life settings where a cascade of care is happening. So there are several system barriers to access to HCV care, which is most important today because usually the key populations are difficult to engage in formal healthcare services. There's a lack of services, inconvenient location, no collaboration among them, no training of professionals. There are still high fees in some regions, and of course there's criminalization of drug use. So many barriers, and besides all, in the vast majority of European countries, we've already seen this slide, only specialists are able to prescribe the new drugs. So nowadays, usually this is the traditional referral model for HCV care, is centralized in tertiary care hospital. So it's really a long journey to get HCV diagnosis in real life, and it's furthermore a long journey from HCV diagnosis to HCV treatment and cure, while at the end of the day, this is actually all that we need. So it's quite obvious that care for our patients nowadays needs to be patient-centered. It means that we need to redefine these models of cascade of care. We need to bring HCV care to the community where patients simply access services. And this is also the ELPA latest study showing that the level of integration of HCV care within the existing services throughout Europe is really low, particularly for key groups. You see only the dark green countries have this higher integration, and the same is for the adaptation of HCV services to key populations, so still very low among European countries. However, at the beginning of this year at EASL, perhaps you were there, we say that there's little evidence exists that these models of care work in a real-life settings. But just last week at the INSHU meeting in Montreal, there was a new publication showing that actually these models of care work in real-life settings. So these are the key populations, and here on the right side you see the countries where these models really work. Models work for PWITs, models work for prisoners, homeless people, sex workers, migrants, and MSM. Where are these models settled? Either in low threshold settings, primary care, prisons, high threshold settings, rural, pharmacy, mobile vans, and so on. And who are the providers? A variety of different providers, either multidisciplinary, GPs like peers, nurses like pharmacists, and so on. Let me just show you a few examples. This is the one from Scotland, where testing and treatment is offered within community pharmacies, and you see on the right side the very high response. The other one is from Southeast England, like one-stop HCV clinic at 2 major homeless hostels, and you see at the right the SVR rate being very high. Another one from prison in Spain, where prison healthcare facilities are used, and on the right side you see the SVR, very high rows. And I can tell you one from my country, very high SVR rate with DDA treatment, but again, integration of the services. So to conclude, ladies and gentlemen and dear colleagues, it's quite clear that HCV care in key populations needs to be patient-centered. Access to care needs to be redefined and decentralized, because it's quite obvious that one size does not fit all. So multiple models and interventions adapted to specific settings are needed. This is a mobile van going around Australia, and this is all the group that is doing it actually, and it works. So simplicity, scalability, and patient-oriented, that is the hallmark I would tell to you. Thank you.